Welcome back to the deep dive. Our mission here is pretty simple. We take really dense source material. Today, it's the Immunology and Serology 6th edition textbook, and we pull out the core knowledge you actually need.
That's the goal. We're cutting through all the noise to give you a really solid, foundational overview of clinical immunology. Perfect for, a med student on rounds or a lab professional who just needs a quick refresher.
Okay, so let's start at the very beginning. If we strip everything else away, the entire massive function of the immune system really boils down to two things, right?
Two critical things. First, it has to recognize the difference between self, that's you, and non-self, which is the threat.
And second,
Defend the body against that non-self relentlessly.
and this idea is, it's not new. It's not some modern concept.
Oh, not at all. What's so fascinating is that the foundation for this goes back thousands of years. I mean, as early as 430 BC, during the plague in Athens.
Thucydides, right.
Exactly. The historian Thucydides, he wrote down this incredible observation that people who survived the plague, they almost never got it again. They were, in a word, immune. That's really the historical bedrock of this whole field.
A truly ancient observation. So, to handle this constant threat, the body has, what? A two-pronged approach.
It's a two-pronged approach,
Huh.
a dual defense system. We call it innate immunity and adaptive immunity. Think of them as two different teams working in shifts.
Okay, so give us the breakdown. What's the timing on this? Who is the rapid response team and who are the specialists?
Innate immunity is your rapid response. It's the first line, always on duty. It kicks in almost instantly. We're talking 0 to 12 hours after an infection.
And what does that include?
It starts with the simple stuff, physical barriers, your skin, the linings of your gut, and your lungs. Just physically stopping microbes from getting in.
But what if they do get in? If the wall is bruised?
Right, then the internal systems take over. You've got physical removal, like the cilia in your lungs, sweeping things out. You have chemical weapons like the acid in your stomach.
Harsh environments.
They're very harsh. And then on a cellular level, the innate system deploys phagocytes, natural killer cells. The complement system. They all work to just eliminate microbes, fast and non-specific.
So it hits first, asks questions later.
Exactly. Which brings us to the second team, the adaptive immune system.
The specialists. This is the one that takes a while to ramp up, isn't it?
It takes a while, yeah. Usually 3 to 5 days, maybe longer.
Yeah.
And that's because it's being custom built for a very specific invader.
So this is where B cells and T cells come in.
This is their show. The lymphocytes B and T cells get activated. They create antibodies, effector T cells, that are designed to recognize and eliminate that one specific agent. It's the memory of this system that gives you long-term protection. That's why Thucydides' observation was so spot on.
It sounds like a really coordinated effort. So among all these different immune cells, what are their main jobs? Who does what?
We can break them down by function. You have the lymphocytes, which are the strategists. They handle the specific recognition of antigens.
Okay.
Then you have the effector cells. These are the soldiers, the ones that actually eliminate the microbes. Think phagocytes.
But there has to be a link between them. How do the strategists tell the soldiers what to do?
Ah, yes. The vital cellular bridge. That would be the dendritic cells.
They are often called the sentinels, right?
Precisely. Their job is to capture antigens. They literally pick up pieces of the invader, and then they present those pieces to the lymphocytes. They are the essential link that activates that whole adaptive response. Without them, the T cells wouldn't even know what to attack.
Okay, that makes sense. Let's shift a bit to the chemistry of it all. What exactly triggers this whole response? We hear antigen, immunogen.
So the trigger is technically an immunogen. It's a macromolecule, usually a big protein or a complex polysaccharide. And its job is to generate an immune response.
And some are better at it than others.
Oh, definitely. The key takeaway here is that complexity is king. The more complex the molecule, the stronger the immune response. A big complex protein is a much more powerful immunogen than, say, a simple repeating lipid.
And the immune system doesn't see the whole protein, does it? It focuses on specific parts.
Correct. It focuses on these small, prominent areas on the surface called epitopes, or antigenic determinants. Those are the little flags that the B and T cell receptors actually recognize and bind to.
And the B cell's primary weapon against these epitopes are antibodies, or immunoglobulins.
Right. Immunoglobulins are agay. They're just specific proteins we find in body fluids, blood plasma, tears, saliva. In the lab, they were first isolated in what's called the gamma globulin fraction of protein using a technique called electrophoresis.
Which just separates proteins by size and charge.
Basically, yeah, it's a fundamental technique.
Okay, this is where it gets really interesting for me. The structure of these things dictates their function. Let's zoom in on two key classes, IgM and IgA.
Great choices. Let's start with IgM. Functionally, think of this as the massive first responder. It exists as a pentamer.
So 5 units all joined together.
5 individual antibody units, all linked together by something called a J chain. And because it has this huge structure, it has 10 binding sites. IgM is incredibly efficient. It's way better than IgG at things like agglutination.
That's the clumping of particles.
Right, clumping things together. And crucially, it's a powerhouse at activating the complement cascade. It's the first antibody made in an immune response.
So super efficient, but maybe not as stable as others. What about IgA, the one that guards our mucosal surfaces?
IgA is fascinating. Its form actually changes depending on where it is. In your blood, it's mostly a standard monomer. But in secretions, your saliva, your tears, breast milk, it's mainly a dimer, 2 units joined together. We call it secretory IgA.
It has extra armor.
It has extra armor. It includes a protective piece called the secretory component. This piece wraps around the IgA and protects it from being, well, chewed up by digestive enzymes in your gut or other harsh environments. It's a brilliant piece of design.
That stability is critical. And speaking of design, that specificity led us to one of our most powerful modern tools, monoclonal antibodies.
Absolutely. Monoclonal antibodies, or mAbs, they're cure antibodies, all cloned from a single cell, all designed to recognize one single epitope. We can make them in the lab using something called hybridoma technology.
And their use in the clinic is just huge.
It's enormous. We use them for everything. For cell analysis, like figuring out what kind of leukemia a patient has. For basic blood banking, like RBC typing. And of course, for really targeted cancer therapies, where you can deliver a drug directly to a tumor cell.
Okay, so we've covered the tools. Let's move on to the cleanup crew. The phagocytes. What are their most critical roles?
Their core job is phagocytosis, eating, and killing. We can split them into 2 main groups. First, the mononuclear phagocytes.
Monocytes and macrophages.
Right. Monocytes in the blood, macrophages in the tissues. They're really good at taking care of intracellular parasites, things like M. tuberculosis. The macrophages in the spleen are also essential for clearing out old red blood cells and for building immunity to malaria.
And the other group?
That would be the neutrophils. These are the frontline bactericidal specialists. Their main weapon is the oxidative burst.
A chemical attack.
A powerful chemical attack. They generate a flood of toxic oxygen radicals using something called the myeloperoxidase system, which involves hydrogen peroxide to just destroy bacteria inside themselves.
This sounds absolutely essential for survival. So for the students out there, what happens when these systems break?
Well, the results are catastrophic. Take chronic granulomatous disease, or CGD. In these patients, their neutrophils can't produce that oxidative burst.
So they can swallow the bacteria.
They can swallow them, but they can't kill them. And this leads to these chronic, unresolved infections and the formation of these granulomas, these balls of inflammatory cells. They get awful recurrent infections from catalase-positive bacteria and fungi.
And how do you nail down that diagnosis in the lab?
The best test, the gold standard, is the neutrophil oxidative burst assay, which is done using flow cytometry. It directly measures whether or not the cells can make those toxic radicals.
And what if the problem isn't killing, but just getting to the fight in the first place?
That brings us to another condition, leukocyte adhesion deficiency, or LAD. It's a rare genetic disorder where there's a defect in the adhesion molecules on the neutrophils, the integrins.
So they can't stick to the blood vessel walls.
Exactly. They can't crawl out of the bloodstream to get to the site of infection. They're effectively trapped. And clinically, you see these severe, recurrent, often fatal infections because the body's first responders literally can't respond.
You mentioned flow cytometry again. Let's just pause there for a second. It seems so central to the modern immunology lab. What is it really?
Flow cytometry is an incredible technology. It lets you analyze millions of individual cells one by one very, very quickly. You use monoclonal antibodies that are tagged with fluorescent dyes called fluorochromes.
Like FITC and PE.
FITC and PE are 2 of the most common ones, yes. So you stain the cells, and then you run them through the instrument. As each cell passes through a laser beam, the dyes glow, and a detector picks it up. This lets us count and characterize very specific cell populations.
And in the clinic, what's its main use?
The daily workload is really focused on 3 main areas. First, about 80% of it is immunophenotyping for cancer, diagnosing and classifying leukemias and lymphomas.
Okay.
Second, it's essential for monitoring HIV/AIDS patients. We use it to get an accurate count of their CD4 plus helper T cells. And third, we use it to quantify CD34 plus cells for stem cell transplantation.
Okay, let's shift to the lab itself. For any of this to matter, the results have to be reliable.
Hmm.
What are the bedrock principles of quality control in serology?
It all comes down to quality control, QC, and quality assurance, QA. And it's so important to know the difference between accuracy and precision. Accuracy is how close you are to the true value. You get that through good calibration and standardized methods. Precision is about reproducibility. If you run the same test 10 times, how close are the results to each other? You have to monitor both.
And let's touch on the two foundational reactions in serology, agglutination and precipitation.
These are visual reactions.
Hmm.
Precipitation is when you mix a soluble antigen with a soluble antibody, and they form a visible, insoluble complex, a solid.
And agglutination.
Agglutination is the visible clumping of particulate antigens, things that are already solid, like bacteria or red blood cells, when you add the right antibody.
And for both of these, the ratio of the ingredients is everything.
Absolutely critical. You have to be in what's called the zone of equivalence, where you have the perfect balance of antigen and antibody to get that maximum reaction. Too much antibody, that's pro-zone, or too much antigen, post-zone, and you might see nothing, a false negative.
Which could be dangerous. And that danger brings us to safety. There's one rule every single healthcare worker needs to live by.
It's called standard precautions. It's a mandate from the CDC and OSHA, and the rule is absolute. You must treat all human blood and other body fluids as if they are infectious for blood-borne pathogens.
No exception.
No exceptions. HIV, hepatitis B, you assume every sample is a potential threat. And part of that mandate is that employers have to provide the hepatitis B vaccine for free to any employee at risk.
Okay, let's wrap up with a practical example of how important context is. Let's talk about PSA, prostate-specific antigen.
PSA is a perfect example of why you can't just look at a number. PSA is prostate tissue specific. That means it comes from the prostate. But, this is the key, it is not prostate cancer specific.
Meaning other things can make it go up.
Exactly. You'll see high levels in cancer, of course. But you can also see it in completely benign conditions like BPH in a large prostate, or an infection, or even after recent ejaculation. So a single high number doesn't mean cancer. It means you need to look at the whole clinical picture.
That distinction, tissue-specific versus disease-specific, that's the kind of critical detail we're trying to pull out here. This has been great. We've covered innate versus adaptive immunity, key players like IgM and IgA, what happens when things go wrong with CGD and LAD, and the lab essentials, from flow cytometry to basic safety.
It's really a journey, isn't it? From Thucydides just noticing something strange in ancient Athens all the way to the incredible precision we have in the lab today. It just reminds you that understanding these fundamentals is everything. It's the only way the knowledge becomes useful.
Well said. To help you lock this in, we'll leave you with a short review exercise. Imagine you're looking at a patient's history, and it strongly suggests an immunodeficiency of the innate system. We talked about phagocyte defects. So your task is, briefly describe the primary functional deficiency you'd find in chronic granulomatous disease, CGD, and then explain the best laboratory test used for its specific diagnosis.